So welcome, everyone. Good evening. Welcome to our newest edition of The Right Dose. This webinar is entitled Using Web-Based Tools and Resources to Support People Living with Diabetes in Pharmacy Practice. And guess what? The PowerPoint's not working in this beautiful way that it was supposed to. Oh, there it is.
Maybe it's just slow.
Yeah, no. Oh, that's true. My name is Ruth Ackerman. I'm the Director of Professional Development at the Ontario Pharmacists Association, and it is slow. And I'll be the moderator for this evening. So on today's agenda, I'm going to talk to you a little bit about OPA, just in case you don't know who OPA is and why we're doing this 100 years of insulin celebration. And then I will introduce today's speaker, who will guide you through today's presentation. We'd love to hear from you, so please put your questions in the Q&A, and at the end of the presentation, there will be an opportunity to ask Susie your questions. If you'd like the handout, the presentation was sent to you an hour ago. You have to go to Dropbox, and it's right there. So let's keep going. So for those of you who may be new, OPA is Canada's largest advocacy organization and professional development provider for pharmacy professionals across Ontario. With over 10,000 members, OPA is Canada's largest advocacy organization and is committed to enhancing the pharmacy profession and excellence in patient care. So this year marks the 100th anniversary of the discovery of insulin. And OPA is excited to partner with BD Canada, one of the largest global medical technology companies and Essentia Diabetes Care, a global company dedicated to improving the health and lives of people with diabetes, to celebrate this momentous and most important anniversary. We're having a little trouble. Oh, there we go. There we go. Discovery. And this is our logo. The revolutionary discovery of insulin was made in Canada by Sir Frederick Banting and assistant Charles Best. As leading medical advancement, insulin has fundamentally changed the lives of millions around the globe. Healthcare providers like pharmacy professionals have played a key role and have been instrumental in helping patients manage this disease. And so to commemorate the Nobel Prize winning discovery of insulin, OPA, BD, and Essentia are collaborating to provide a series of online events such as this one this evening, in addition to more live webinars and podcasts. The events and programs recognize this milestone and focus on providing valuable guidance and resources for pharmacy professionals so that they can continue to support patients with diabetes. As accessible healthcare providers, pharmacy professionals are integral members of a diabetes care team that assists patients with insulin delivery and the best possible management of the disease. If we examine the history of pharmacy, the pharmacist scope of practice has evolved substantially since the days of insulin discovery. Added to this expanded scope was the introduction of the new regulated healthcare professional, the registered pharmacy technician. The ability of pharmacists to work collaboratively with an additional healthcare professional with an aligned focus has opened up the opportunity to provide expanded clinical care. Also, both professionals can apply their education to the fullest to help patients and those affected by this disease. To learn more about the history of insulin and pharmacy's involvement, please visit our website. So tonight we're going to hear from you can start taking it now, Susie, to an individual who will be no stranger to many of you, Susie Jin. Susie is a community pharmacist. I'm going to stop share so you can take it. Is a community pharmacist providing appointment-based patient care while collaborating with the patient's healthcare team to support coordinated care. She is a certified diabetes educator, certified fitter of compression therapy, and certified respiratory educator. Susie is a co-author and member of the Dissemination and Implementation Committee of Diabetes Canada Clinical Practice Guidelines, and she has co-authored Wounds Canada Best Practice Recommendations. In 2020, Susie was honored by with the Diabetes Canada Charles H. Best Award, a national award that recognizes a healthcare professional who has made a significant difference across Canada towards improving the quality of life of individuals living with diabetes. Post-COVID-19, which is hopefully close because over your hard work, pharmacists, Susie is looking forward to hugging friends and colleagues all over the world and finishing her last of 6 world major marathons. Wow. Take it away, Susie.
Thank you, Ruth. So sound is all fine? Right,
Yep.
Ruth, you can hear me?
I can hear you.
Sound is all good. Perfect. Thank you so much, Ruth. I thank you everybody for joining me. I know that it's Thursday night on a beautiful night, and so it really means a lot that you've given your time to be with us, me and Ruth from OPA. I really do want this to be as collaborative as possible. I love when we were able to do presentations in person and I could actually really connect with you. So we are going to try to do as best as we can. So please use the chat, use the Q&A. I have both so that I'm watching both. Ruth, interrupt, monitor it too. I do want you guys to get as much as you can out of this. So if I'm kind of touching over things and you want me to go into more detail in anything, please let me know. I did try to keep it almost brief so that it does allow you to say, hey, can you, expand on whatever concept that I might have covered. But I have been blessed to be doing diabetes care in my pharmacy, more specific diabetes care. I think we all do it. We definitely all do it in our pharmacies. But I think what I ended up early in my practice is I actually worked at the Diabetes Education Center. I was in a small town. I didn't know a lot of people, and I just reached out and said, hey, can I get involved? And because I got to see how diabetes education was practiced in the diabetes education program, I then was able to apply a lot of the principles that we did there, whether we did individual appointments or group appointments. And I did that in my pharmacy. That actually worked out to be very helpful when we had, quite honestly, shortages, and we actually had downsizing in our local hospital. We didn't have diabetes education. So I think that the role that the community pharmacist has to play is very much collaborative within the whole healthcare system, which is very much individualized to where you practice. I think that access to diabetes education is huge, and that's what we are doing. And that by giving that patient a choice to either come to see you or come to diabetes educators if you have access, understand where your role is. We don't want to duplicate, but we want to make sure we're facilitating care and working within the team. And there's just different ways to do that. And so if you wanted to ask me about how that works, then I'd be happy to go into that in more detail as well. Okay, so today the learning objectives are that we're going to, by the end of this 1-hour session, we're going to be able to apply the updated Diabetes Canada Clinical Practice Guideline as it pertains to people with type 2 diabetes with cardiorenal disease, or those who are at risk of cardiovascular disease. The second learning objective is to apply that same Diabetes Canada Clinical Practice Guideline update as it pertains to people with type 2 diabetes to achieve target glucose parameters. And finally, to recommend and start and adjust insulin therapies in our practices, especially because we are celebrating that 100th year of insulin. Okay, so let's start with the first learning objective. So we're going to open the poll. Ruth, I'll have you open the poll. My 60-year-old person, and so I left it very general. This polling question is very similar to how we would do it in our practices, right? We're in the middle of, we have a hospital discharge, and my 60-year-old person with type 2 diabetes has been discharged from the hospital after experiencing a heart attack. And so I'm going to open the poll and ask people to answer, of all of the listed agents, which ones should we be automatically considering? So, we're doing a meds check. They've just been discharged from hospital. We know that they've just had a heart attack. Which one should, in our head, we should be saying they should be on these agents? And if they're not, we should be investigating why they're not on these agents. And so all of them are correct except for one of them listed. Ruth, I'm going to have you monitor that because I can't see who's voting. And I'll have you close it when you think it's time to close.
So yes, we have quite a few people. I'm not sure if I can close it now because for some reason, the first two questions are coming up at the same time. So, so I'm just going to leave it open. So just answer number one, and we can answer number two at the end. So we have 72% of people are putting them on insulin. 70%. And then the runner-up is at 15% is a GLP-1 RA and or SGL2.
Excellent. Okay, so if you like, we can close that and then we will discuss the answer.
Yeah, I'm just going to leave the poll there for the second question.
Oh, actually, well then I'm going to minimize it or somehow close it on my screen.
You want me to minimize it? I can certainly do that.
Sure.
Let me get it out of your way. How's that?
Okay, thanks, Ruth. So the answer is the one that is incorrect is insulin. So they should be on, or there should be a conversation as to why they're not on a statin, an ACE or an ARB, ASA, and they should be on either one of a GLP-1 or an SGLT2 or both. They could be on both. Okay, so let's find out how we would find that answer. And so this is what I actually do in my pharmacy, because I find that sometimes off my head and truth. So many times, you know, a new guideline comes out and they change it and so forth. So I always like to just keep using websites. And so that was the whole point of today's presentation. You can see that I now have the Diabetes Canada website up. So this is what I have marked as one of my favorites. It's guidelines.diabetes.ca. And one of the ones that I use in my pharmacy a lot is the quick reference guide. And so literally somebody's in my pharmacy, they've been discharged, and I'm going to be doing an appointment or whatnot. And I have some dedicated time to them. And I'm telling them, listen, right medications, or do we need to investigate as to what medications you should be on? So I've opened up the quick reference guide, and I'm going to go down to the panel that talks about which cardiovascular non-antihyperglycemic medications are indicated for my patient. Okay, and so we can see that this person has just been discharged with cardiovascular ischemia, silent would be more like angina, meaning add full MI. So they have cardiac ischemia. So yes, person should be on statin plus an ACE or an ARB plus ASA. Now we'll take a look at some of the footnotes there. I think that that's also important to look at. So do you see how what they're saying is that independent, when we look at this, they should be on a statin. And generally we would say highest tolerated dose, so max tolerated. But you'll see that dose adjustments or additional lipid therapy is warranted if the lipid target is not being met. And the lipid target in this case that they've actually specified, but there are others, is an LDL cholesterol of less than 2.0 millimoles per liter, right? So you'll see that they're on a statin, and that's just for cardiovascular protection. If they're not at target, then they might be on additional agents, whether we're being an ezetimibe or a PCSK9, things like that, that we could add more. But having said that, they should be on a statin for cardiovascular protection. The other thing that they should be on is an ACE or an ARB. And what I also like about the quick reference guide is you don't have to memorize it, but sometimes people will say, well, which one would you recommend? And you'll see that I'm highlighting it there. Well, it's actually double highlighted, but it's there that says which one should we recommend. And you'll see that it is perindopril 8 milligrams. And so, and that's from the Europa trial, or ramipril 10 milligrams from the HOPE trial, or telmisartan 80 milligrams from the OnTarget trial. And because those are the agents and the doses that have demonstrated cardiovascular protection, if at all possible, if it's tolerated, then those are the doses I will push for. So if somebody was discharged from the hospital with perindopril 4 milligrams, maybe not immediately on discharge, but you know, sometimes after about 2 weeks to a month, they certainly are followed up by their family doctor. I might send a letter at that point and note a professional opinion suggesting that the dose be increased because of the Europa trial to secure, or to, as that's the that's the evidence-based dose for cardiovascular protection. So that's an example. That's another little footnote that's of help. And then finally, the footnote 3 would be that ASA is not routinely used for primary prevention, but of course, in our case, this person has had an MI. So we are using it for secondary prevention. And so it is indicated. And that it also continues on to say that if the person is ASA intolerant, that we could consider clopidogrel. And so that's actually an important point, because sometimes I'm so eager and I'm doing my med review and I'm, oh, this person just had an MI, and I'm just boom, 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 what should the person be on? And the person should be on ASA, and I don't see ASA. And I ask them if they're purchasing it over the counter, because of course that's important, because we don't always have that on file. But I miss the fact that they're on clopidogrel. So just letting you know that any antiplatelet, generally, I would just not have to necessarily look at making a recommendation for ASA and considering it being missed. Okay, so hopefully that answers the first part of our question, of our poll. Which agents should they be on automatically post-hospital discharge, or post having an MI more specifically, would be the statin, the ACE, or the ARB, or the ASA. So let's find out about what do we mean about the GLP-1 or the SGLT2. And I think this is another important conversation, and what tool do I use? Because many times people, for example, will be discharged from the hospital and they'll not be on it. And so rather than me just coming out and saying, oh, you need to be on boom, 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 if I use this tool and they see that it is the Diabetes Canada website, it really lends a lot of weight to what I'm saying. And it really says that I'm not pushing meds on you. I'm investigating how we can protect your heart. And if I don't investigate and look at all the different agents, then I actually haven't done everything that's evidence-based that would actually has been shown to help protect your heart. So let's look at the second thing we could look at. So this is that first panel that I looked at from the cardiovascular non-anti-hyperglycemic medications. But if I go up, you'll see that on the earlier panels, so at diagnosis of type 2 diabetes, so this person has diabetes, right? And you'll see that the first thing we do is we start lifestyle changes plus or minus metformin. So whether we start it immediately or we start it later, either way, in this case, we're on metformin. And now this person, we're on panel 2, figure 2 here. And you'll see that this person has been, in our situation, discharged from the hospital post-MI. So there has been a change in clinical status, right? So what we're saying is that doesn't matter if the A1C is at target or not because of the or, right? There has been a change in clinical status. And in this case, this person has atherosclerotic cardiovascular disease. And so in this case, we want to add or substitute an anti-hyperglycemic agent with demonstrated cardiorenal benefits. So what do we mean by add or substitute? So in this case, I actually, oh my goodness, I have to turn on my notifications. This is hilarious. I think, do not disturb. Sorry about that. Okay, so what do we mean by add or substitute? So in this case, what we're saying is that, and I gave you a very general overview, your person's discharged and all you know is that the person had an MI, well, and the person has type 2 diabetes. So if the A1C was actually above target, or if their glycemic levels, whether they have continuous glucose monitoring and you can see that they are above target, then of course adding an anti-hyperglycemic agent would be fine. If on the other hand, they actually are also on other agents, whether it be a DPP-4 or a sulfonylurea, or maybe they already are on basal insulin. But if they're not on these cardiorenal protective agents, and we're looking at adding a cardiorenal agent, and they are at A1C target, that's when we would substitute. In other words, maybe we would cut back on the sulfonylurea while we increase or add on a GLP-1 or an SGLT2, which is where we're going. So we're going to go to figure 2.1 here. Okay, so we're talking about adding or substituting an anti-hyperglycemic agent with demonstrated cardiorenal benefits. So in this case, we're looking at this column right here. This person has just been discharged with atherosclerotic cardiovascular disease. So in the event that this person has established cardiovascular disease, we could recommend a GLP-1 receptor agonist to lower the risks. I don't know if you can see my cursor, but what the GLP-1 has been shown to do is the GLP-1 has been shown to lower the risk of MACE, major adverse cardiovascular events, right? Or we could recommend an SGLT2, which has grade A evidence to lower the risk of major adverse cardiovascular events. We could recommend an SGLT2 to lower the risk of hospitalization for heart failure, right? Because you can see from this chart that the SGLT2 has been shown to lower the risk of hospitalization for heart failure in people who have established atherosclerotic cardiovascular disease. So these populations, when you add these agents, have been shown to lower these risks. So the same sort of thing, if we were writing a POP, we could recommend an SGLT2 to lower the risk of the progression of nephropathy in a person with established atherosclerotic cardiovascular disease. And you could actually put open bracket grade B evidence close bracket. Okay, so what I'm trying to do is I was trying to show you how I will use the quick reference guide, right? So remember, literally all I did is from the home page, clicked on quick reference guide. That's how it opened. And the wording is all right there in the chart. So if I go back to here, you can see I can open up my OPA pharmaceutical opinion, and some different computer systems, you can use whatever computer system you have, but I liked this one, so I use this one. So this one, you can see I'm going to have, in this case, you would fill out the patient information on your own. You could fill out the prescriber information. So just in the interest of trying to make things big, I blew up the middle part here. So I'm going to just forward slide, and you can see I kind of blew it up. So if we were going to write those exact kind of wording in my POP, starting on the left-hand side, so number 3, what do we need? Well, in this case, I think, the closest one is that the patient needs additional drug therapy. Needs could be strong, or it could be we should consider additional drug therapy for this patient for sure, right? And in fact, some people would absolutely say that patient needs it and would benefit from it. So when I continue on to the right-hand side, you'll see that I filled out in this case, and I have no sense of creativity, so my patient's just AB. So AB experienced an MI, and you could insert that date, and would benefit from cardiorenal protection. Note, as both the GLP-1 and the SGLT2 exhibit glucose-dependent effects and are not affiliated with hypoglycemia, this recommendation is made independent of A1C. So even if A1C is currently at target, I don't need to know blood work. I know that this person would benefit from being on either an SGLT2 or a GLP-1. And so what do I mean by glucose-dependent effects? What we mean by that is that if the sugar is high, the GLP-1 or the SGLT2 is more effective. It knows to work harder to bring the sugar down. In the event that the sugar is actually not too high, it's actually very close to target, it actually doesn't have a strong effect. So it's actually, and that's why it doesn't cause hypoglycemia, because it knows when it's getting down, when it's very high, it knows to work, and it actually works more effectively to lower sugar. And then as the sugar comes down to target, it actually just doesn't need to work as much, but still confers cardiovascular or cardiorenal protection. Level of urgency, this is a judgment call. In my case, I wrote that, and I wonder what you guys would have written, but I wrote medium. Usually I never write low because, sometimes they never look at low, but certainly high. I don't want to be disrespectful. And, we could start this within 2 weeks or, that type of thing of an MI, and it would not be urgent in that case. Okay, so looking at the actual recommendation I would write, this is just an example. But in this case, I wrote, according to the Diabetes Canada 2020 update on the pharmacologic glycemic management of adults with type 2 diabetes. And so just putting it out there, I get all my wording from the from Diabetes Canada. So if I go over to here, where did I get Diabetes Canada 2020 update on the pharmacologic glycemic management of adults with type 2 diabetes? If I go over to the website again, so back to the home page, and you'll see that on the 2020 updates, I got those words, the pharmacologic glycemic management of type 2 diabetes in adults in the 2020 update. So again, just showing you that a lot of the wording comes straight from there, and it sounds pretty, you know, oh, you sound smart, but it's really, you're just pulling it literally out from there. So now that AB has established atherosclerotic cardiovascular disease, and you probably know where I got established atherosclerotic cardiovascular disease. So remember from here, I took the wording right from the chart that I'm explaining why I'm making that recommendation, right? So in this case, now that AB has established atherosclerotic cardiovascular disease, AB would benefit from a GLP-1 receptor agonist or an SGLT2 inhibitor to reduce the risk of, and in this case, I wrote MACE because space is limited. And technically you see how grade A evidence had shown that both the GLP-1 and the SGLT2 have evidence, have grade A evidence for that. But I could have written that AB would also benefit from an SGLT2 to lower the risks of progression of nephropathy and hospitalization for heart failure. So we could have written those additional benefits there. Anyway, the following agents have demonstrated cardiorenal benefits, and I could have written, please choose from one of the following agents which have demonstrated cardiorenal benefits. Okay, and so these are the agents there that are actually in a different panel. So let's go to that panel. How did I find out which ones have demonstrated cardiorenal benefits? So I'm going to go back to here and see how this happens to be figure 2.1. If I continue down, you'll see that these are the agents with proven cardiorenal benefits. And so dulaglutide, liraglutide, semaglutide, and then within the SGLT2 class, we have the canagliflozin, dapagliflozin, and empagliflozin. And so you can see that those are the ones that have proven cardiorenal benefit. And so I've written them in there, okay? And then if I continue along, I kind of filled out the action plan, because I think it's important that we don't just make a recommendation, but we actually let the primary care provider know how we're going to follow up. If I make a recommendation, it's important to know who's following up. And sometimes it's an example where maybe I'll make the recommendation and maybe the diabetes educators are also involved. And so I'm going to copy them on this when we get the results back, and maybe they'll be involved in the follow-up. A lot of it, sometimes I'll work with the patient and ask the patient, when is your next appointment with the diabetes educators, or when last have you been seen by the diabetes educators, and either refer them back in, or, you know, depending if they actually want to continue seeing you, then that's our responsibility to figure out what works. And sometimes it's a matter of who has the time. We don't need to do it all. We can, but we don't need to. And so I think that's important that we just facilitate access to care, right? Get this person the right care that they need post an MI. So for example, in this case, the action plan is the pharmacist will start AB on the prescribed agent, whether it be the oral or the injectable agent. You know, we can do that in our community pharmacies. We would follow up and monitor for adverse effects. And I know that sounds silly, but I really feel, and so many times, if you actually start anybody on an SGLT2 or a GLP-1, so many times, if we don't actually educate them properly on possible effects, then when they experience them, they automatically stop it. They don't even call you. So many times it's important to explain to them what they could experience and how to minimize GI stomach effects from the GLP-1, for example, or the frequent urination from the SGLT2, little things like that. I think if you can minimize adverse effects, then in many ways they're prepared for it and they know what to do and they don't stop it unnecessarily. But then sometimes it's so important to do a follow-up phone call, whether that be 3 days later, 7 days later, 14 days later, 28 days later, that type of thing. You'll see that there's certain cut points that I find that are helpful for making sure that, that the person is tolerating it well. And a lot of that time depends on the up titration of the agent that we used, whether you're up titrating in every 7 days or every 4 weeks or every month, for example. All right, so for example, continuing along the lines, we have the follow-up and monitor for adverse events. And then we have, if starting in, and I just did it very generally, but if you're starting an SGLT2, then I will counsel on sick day management. If starting on a GLP-1, I would stop the DPP-4. If AB is on other agents that are affiliated with hypoglycemia, such as a sulfonylurea or insulin, then we need to not only dose adjust. So if I jump over to here, we need to adjust, so down titrate other glucose lowering agents. I'm saying the A1C is really high, where you have them on any kind of glucose monitoring, and you're seeing that the numbers are above target, then sometimes I actually leave the dose as fine and add on my other agent because, you know, they're above target and we need something to bring them down. If on the other hand, they're actually actually close to target, then when I add on this, I lower that, and I add on this and I lower that type of thing. So adjusting the dosing of the agents is important. Somebody needs to be responsible for that. And you'll see that sometimes you make the first adjustment at 4 weeks, and then you might need to do another adjustment, 4 weeks later, that type of thing. Of course, if they are above target and they've just had an MI, for example, they are often in a very actionable stage of change, right? They might have been contemplative or in preparation to, I know I have to exercise, I've been thinking about exercise and now I'm going to, or things like that, or I should have been eating better all along, but I haven't been, and I plan to, or I will be making better strides to eat more healthy. So healthy means healthy foods. So if they're going to be making those food and healthy behavior interventions, then definitely down titrating, especially when we're adding other agents, is very important. But if they are on agents with hypoglycemia, affiliated with hypoglycemia, so if they're at risk of hypoglycemia, then I think it's also important that someone, whether it be us, community pharmacists, or I should say just community, any pharmacist, whether we are going to be counseling on the management and prevention of hypoglycemia, or whether we're going to be touching on the Drive Safe guidelines. Somebody has to do that, and somebody should take responsibility for it and then follow up that it has been done. Okay, so key points. And actually, before I hop over to key points, I just want to take a look at some of the questions. So Colleen Hicks was asking about why consider a max tolerated statin. If the person's at target, why not just leave at the lower doses? You know what, that's a good question. And I think many times it is actually individualized. Having said that, if the person was on whatever dose of statin and it wasn't actually the max, let's say, and they then had an MI, often we actually need to consider increasing it. There should be a conversation about that at least, but many times the primary care providers, or certainly at the hospital, it's already been done. But I think it is still a good conversation to have, because whatever dose they were on, and now of course they still had an MI on top of that. There's another question. I have a very elderly palliative patient, and I'm wondering why they are being aggressive about lowering her blood sugars. Excellent question, Colleen. And actually, you know what? I'm going to be actually touching on that in the second case. So if I don't answer it appropriately, can you nudge me again? But you're absolutely correct that many times it's a matter of education. So maybe if I show you the tools that I've used to do my education of my colleagues, including long-term care colleagues, then definitely maybe that'll help, and you could use those tools to let them know, listen, we don't need to go that route. And in fact, there's actually excellent end of life and palliative care, because palliative care, you can be palliating for a long time, right? Which is not necessarily the same as end of life. But there are excellent palliative care guidelines in, quite honestly, the American Diabetes Association Standards of Medical Care for Diabetes. What targets are reasonable for this above case? Good question. So Colleen, actually that's all in the second case, because, well, yeah, so I'm gonna get to answer those questions in my second case. But again, if I don't bring them up well enough or whatnot, then please nudge me again. I'm just gonna double check the chat box and nothing there. Okay, so let's take a look at what are the key points of what we've already covered so far. And the first thing is just to talk about the fact that we would recommend the GLP-1 so they really only need to be on one for cardiovascular or cardiorenal protection, right? And this is independent of A1C. And I know I wrote then it is a glucose dependent, because it has a glucose dependent effect and it's not affiliated with hypoglycemia. We don't worry about necessarily going lower. And so we don't care about what the A1C is, even if they're at target, we want them on it for the cardiorenal protection. But I think the other thing that's kind of interesting for us to note is that we're now going to start seeing the SGLT2 class, the GLP-1 class being used in people without diabetes, right? So certainly, I know that we'll see the GLP-1 class used for the management of obesity, and they don't have type 2 diabetes, and yet we are still using that class, right? So again, independent of A1C has nothing to, we don't need to, sometimes we're not even thinking of them as diabetes agents, but certainly agents to manage obesity in the case of the GLP-1 receptor agonist. Or we're going to be starting to see the SGLT2 class being used for chronic kidney disease or for the management of heart failure, independent, so they don't even have diabetes, and we're going to be seeing these agents. And that's going to change around our counseling entirely, because I don't know about you, but sometimes somebody will come to, you go to counsel them on the prescription and you see that it's, let's say, I don't know, an SGLT2, and you say to them, oh, so this is often used, this is being used for type 2 diabetes, and they're looking at you, go, no, I don't have diabetes. The same thing when we would have counseling somebody on metformin and they were using it for PCOS or something like that, nothing to do with diabetes. So again, I think that we just need to be aware that we're going to be seeing these agents not being used in people with diabetes, and in many cases, in this case particularly, we're using these agents for cardiorenal protection. Doesn't matter what the A1C is. Okay, and then the other thing that I wanted to bring up to our attention was the fact that we also touched on, so these are the key points that we touched on, just recalling or making sure that you remember, how do we know who would qualify for the statin or the ASA, who would qualify for the ACE or the ARB, and which drugs would we recommend and what dosing. And I just want to hop over there for one more minute. So if I go back to here and I go down to that same chart that I was here. So remember how I was saying how the example that I had is they definitely had an MI. So of course, all three are there. But you can see, imagine if they didn't have an MI. So the answer is no. So you go down to the next one. Is there microvascular disease present, right? And sometimes we do have blood work, or we have access to blood work. And we would know in that case, they don't need the ASA, because remember, we already touched on the fact that it's not indicated for primary prevention, but certainly secondary prevention once they have cardiovascular disease. And then you could also continue down. Let's say they don't have macrovascular disease, they don't have microvascular disease. The next question is based on age. Are they over 55? Are they over 40? And you'll see that we have certain, what recommendations do we make? So as soon as the person's over 40, type 2 diabetes, actually 40 and diabetes, they should be on a statin automatically, right? Doesn't matter what their cholesterol values are, they should be on a statin for cardiovascular protection. Similarly, as soon as they're over age 55, we should consider the statin and the ACE and the ARB if there are certain risk factors present, and you can see the risk factors are pretty much there. Okay. All right. So hopefully we've covered those. And then the last learning point I wanted to bring out is that the dose, because we were talking specifically about the dose that we use for ACE and ARBs, should be, if at all possible, if tolerated, should be the dose that has evidence-based to show that it actually has the evidence-based dose for cardiovascular protection. Similarly, these are the agents at those doses that have demonstrated cardiorenal benefits. So, for example, I guess if you saw somebody on dulaglutide 0.75, they're not on the dose that was shown to have cardiorenal protection. And same with semaglutide. Now, having said that, I will do whatever I can to get them to the dose that's max tolerated, or the dose that is demonstrated. But I do have a lot of people, many people, because of the benefits that we are seeing from these agents, that really go max tolerated. If they can't tolerate the 0.5, even though I really, when you've worked with them, you can actually many times get them there. But in the rare cases, the 0.1% of times that you can't get them there, then fine, go with 0.25, go with 0.25 plus 10 clicks or something like that. And you'll see that if you count them all, I think it's actually 18 clicks. So I actually go 0.25 and then plus 9 clicks and things like that you can do. But having said that, that's the GLP-1 class. These are the doses for the SGLT2 classes. You'll see canagliflozin comes as a 100 or 300. It was the 100, so the lower dose that showed cardiorenal benefits. If I hop over to empagliflozin, it comes in 10 and 25, and it was the lower of the dose of the 10 milligrams that showed cardiorenal protection. But dapagliflozin comes in 5 and 10, and it was the higher of them that showed cardiorenal protection. So sometimes there's little intricacies in that. Okay, so I'm going to hop over to another one of the questions. What if the patient has been unable to tolerate the statin even at a very low dose? Okay, excellent question. A lot of that is patient education and talking to them and seeing what their goals of care are. I have had situations where they couldn't tolerate atorvastatin, could not tolerate rosuvastatin, whether we even tried generic or name brand, but they were able to tolerate pravastatin. So these are just things that you can consider having a conversation about it. A lot of times it's a matter of, are they willing to try? But you know, I think that it's also very much individualized care, right? We don't want to make them feel bad, but I actually have been able to have people see the benefits of it and willing to try. Okay, so let's continue on. So hopefully we finished delving into the first learning objective. Hopping over into the second learning objective, we're looking at using these agents not necessarily for cardiorenal protection, but how we're going to achieve target glucose. So I'm just going to go back to the quick reference guide. So if I go back to the website and I go back to that figure 2.1 that we were originally looking at. So the first learning objective, the example was the person who had atherosclerotic cardiovascular disease. But any of that would have been the truth if the person had chronic kidney disease or heart failure, or if they didn't have established cardiorenal disease, but they were over 60 years old with 2 cardiovascular risk factors, which are listed here. So whether they're a smoker, they have dyslipidemia, they have hypertension, or they have obesity, which isn't listed there, but certainly that's another risk factor. So, so what we're doing is we're talking about other people. So maybe they are under 60 with 2 risk factors, or maybe they're just newly diagnosed and have none of these things. But essentially, as soon as you have any of these populations, we're looking at this chart first. So that's why that was learning objective 1. So now we're looking at, okay, well, this person doesn't meet any of these criteria. So there's no hard evidence to say we definitely have to go with a GLP-1 or an SGLT2. But now what? Okay, so if I go back to my PowerPoint presentation and we have the now what, right? So now they have type 2 diabetes, and we are really looking at achieving target glucose parameters, right? So let's take a look, and I know Colleen had asked about this. So let's look at what do we mean by target glucose. So I'm going to go back to my Diabetes Canada website, and I'm going to go to the home page. And from the home page, I'm going to go to individualizing your patient's A1C target. Okay, so this is an actual question that I had in my pharmacy. I actually had a patient come into my pharmacy and say, I just came from my appointment with my family doctor. He said my A1C was good. It's 7.6. What do you think? And I'm going to pause there, because imagine if this was you, right? I mean, many of us were in a busy pharmacy and this person has come in and said, 7.6. He says, I'm good. What do you think? And it's not an easy answer, is it? Because for sometimes 7.6, awesome, you're doing so good. And other times, whoa, we really have to work on that. That's not target. So this is where we're going to go. And this is the literal conversation I had with him. So again, this person happened to be 70. Oh, look at that, 72 years old. He really was. I mean, I've obviously been playing with the website because I was testing it, but he was a male. He is a male. He has type 2 diabetes. And this is where I would have that question, right? So don't forget, his doctor said he's 7.6, right? So I could open up the frailty scale, or I could have a conversation. And you and I both know there's different kinds of people who are 72. This guy was crazy. He seriously was so like, he came off the ski hills like two months ago or something like that. So he is a go-getter. He's young. Well, he's driving. He's healthy. He's skiing. He's active. So I would definitely have called him functionally independent. But if you go to the clinical frailty scale, sometimes you can just open this up, and it's kind of interesting when it finally does open, you can see, you can even see for yourself where you fit in. It's kind of embarrassing because most of us are not actually number one. Most of us, very rarely are we robust, active, energetic, motivated. Most of us are not among the fittest of our age, but certainly for him, I would have said he's a number two. I mean, he was seasonally, I told you he just came off from skiing, you know, that type of thing, right? But sometimes you can look at them and just sort of get a feeling for just from here, just what they are, right? And so let's say he was a two. Colleen, in your question, you were saying you have people who are in long-term care. Why are we pushing those targets? And so you can see they might be, and certainly in terminally ill, there might be 9, but or palliative, but you know, long-term care, let's say there are 7s or 8s, okay? But if I go up in here, and I'm going slowly because I find it's hard, I don't want to hurt people's eyes, but in that same chapter, you see that frailty index. So you see my example was a 72-year-old who was functionally independent, and his A1C target based on this chapter, which is diabetes in older people, we would want to have an A1C of less than 7%, right? And you can see, remember we were talking about people with a 6 to 8, you know, an A1C of less than 8.5 is fine in that sort of situation. So this is a perfect example of, you know, what we consider, you know, how do you answer that question? And so when that person came to me and said, I'm a 7.6, what do you think? Well, you know, I looked at him and I pulled this up and I said, you know what, you are not, and I had that other chart and I said, you are not, you know, 4s and 5s, right? So we shouldn't treat you like you're a 4 and a 5, even if you are 72 years old. And so he's the one that said he wants to get to a less than 7% because he was a 7.6, and we worked on it. Okay, so another tool I also used was this one. Actually, no, it was the quick reference guide. And here's the quick reference guide. And he said he was a 7.6. I opened it up. I said, you know what? See this? You are 7.6. You're somewhere in here on the scale. And that would be okay if you were functionally dependent. And that was enough to also explain to him that, you know what, that's not good enough for him. He's not functionally dependent. He's very much functionally independent. And so that was why he was quite willing to work himself to achieve what he needed to do to get an A1C of less than 7. And for him, it's just a matter of tweaking a couple things in his life, because that's just a conversation you have. But that's the thing. How, now that I have this, we know what the A1C should be. So how do we then have that conversation with people? So also, I'll use the quick reference guide. I will literally start step by step, and we're going to assess glycemic control, cardiovascular, and renal status. And remember, in this sort of situation, I have already established that they're not part of the first populations, right? They're not part of the cardiorenal populations or the people who are over 60 and with 2 risk factors for heart disease. So my question is going to be then, let's reinvestigate healthy behavior interventions, right? Let's make sure you're on max tolerated metformin or the renally dose appropriate metformin. And then we're going to discuss what else should we be doing. So we're going to go to figure 2.2 and we're going to talk about what else should we be doing. And that's when we get to this figure. And so then we can have a conversation about, well, what are your goals of care? If you're concerned about, if we want to avoid anything that causes weight gain, then we would try to minimize the use of these. If weight loss is a priority of care, then certainly we can go with these. Of course, between these, if I had a choice, I would go with the one that has proven cardiorenal benefit, even though it's only in high-risk populations. As you know, life is a continuum, so why not try one of these agents? And of course, we get right back to the start of all the different, the SGLT2 and the GLP-1 class as an option post, as right after metformin, a consideration for them. Where does the DPP-4s fit in? So they're right in here. They have proven CV safety, but not cardiorenal benefit. And you can see that there's one saxagliptin that is actually affiliated with heart failure. So because of that signal, we kind of avoid it and choose generally these agents over here for if we had to go with the DPP-4. All right, so hopefully that gives you an idea of a conversation that you could have, certainly starting with the healthy behavior interventions. I really feel that in so many ways that sometimes it's just a matter of tweaking, sometimes just adjusting it, going with a little bit less carbs or more of a low glycemic index foods, and they're able to avoid those postprandial rises. Okay, so let's do another polling question. Ruth, are you okay to open that one up, please?
It should be open now. It's below the other question there. Some people have already answered, but you could.
Perfect. Okay, and so again, I'm not seeing it, so do you want to call out the answers once it comes up?
So confidence level in starting a patient on an injectable agent is, we're kind of mostly somewhat confident.
Okay.
Very few people are not confident, which is nice to see.
Excellent. Excellent. Okay, so then I'm going to hop back over to, good, I was just checking the chat and the question and answers, and there are some questions and I'll come back to those. So I'm just gonna hop over to quickly what I do when I'm starting insulin, because we are celebrating 100 years of insulin. So I just wanted to make sure that we have a checklist and we make sure that we've done everything. So this is also on the website. So if I go back to the website, back to the home page, and if I put in insulin start, funny thing is right there, and you can see that you would find the insulin, insulin pen start, insulin pen start. But anyway, that's where you'd find it. Let me get right into it because I'm running out of time and I do want to answer some questions. So essentially, literally, I feel that if we're going to be doing insulin starts in our community in our pharmacies, then we would want to make sure that we are at least doing exactly what would be certainly on the list of Diabetes Canada, plus certainly what they would be getting if they went to the diabetes education centers as well. So I would be able to go through the whole of the cognitive assessment, which is the clock, and asking them just to make sure. And sometimes it's more of a general, do you think that they're, after speaking with them, are they cognitively able to do it? And by the time you've done the whole thing and they've done a return demonstration, you know if they're capable of doing it or not. You see number two. Number two is actually available if you go to the Fit for Diabetes, and I have on the handout all the different websites that I've touched on. So if you go to the Fit for Diabetes, Fit for Diabetes, and I pulled up the Canada one, you'll see that on the far right here. If I open up that one here, I hope I'm not going too fast, but you can see that there is a PDF that you can open up that actually tells you step by step how to start insulin. And so because most people were quite confident, I am not going to go into this, but I just want to wait for it to open. So I apologize, my internet is actually a little bit slower than I would have liked. Just go to refresh that. And this is the BD Fit for the forum, Fit for Diabetes, that actually has a stepwise approach to how to start insulin. So, oh, funny, I actually raised my hand by accident. Let me lower my hand. Okay, so you can see that if you have to rotate, but most of us are using clear insulin now. And it shows about the different rotation sites and how to dial the dose, how to prime the dose, they're priming the dose, and so forth. Okay, so that hopefully answers number two. Then we can talk about, there's a return demonstration. And just to point out, sometimes, especially if you're starting somebody on, for example, 10 units and then slowly increasing them, they're not going to necessarily get hypoglycemia on the first night. I often will do a blood glucose reading before they leave the pharmacy. So if I'm short on time, I do a blood glucose reading before they leave the pharmacy. I show them how to do this, and then I do a follow-up the next day, because sometimes you don't have enough time, but you know, that's all they need. And then when they come back, you check their sugars again, or you at least take a look at their documentation system that they're doing, so that you're establishing patterns to make sure everything is actually, that they're actually getting it. So hypoglycemia, when I actually have to go talk about hypoglycemia. So again, if you have time, do it. And if you don't, then don't do it till your follow-up, which could again be the next day or 2 or 3 days later. So hypoglycemia, where do I find that? So if I go to the home page, and if I actually search on hypoglycemia, you'd find it. But do you see how this keeping people safe with diabetes? Right here, and you see that there's a hypoglycemia resource. And so that's nice and much faster. And so you can see that you can actually discuss this hypoglycemia resource, which talks about the what, the why, and the how, but particularly the why, which talks about how to prevent hypoglycemia. Okay, so we've talked about hypoglycemia, glucose check. So recommending a monitoring schedule. So of course, they could be doing the capillary glucose monitoring, or they could be doing either flash or the continuous. But one of the nice tools that we have is also available from the Diabetes Canada homepage. If you go to healthcare providers, so when you have time, play around with the website, but on the left-hand side, you see there's tools and resources for healthcare providers, and there's tools and resources for people with diabetes. But it's a healthcare resource. And we're talking about how to manage diabetes. So if I pull that up and I go down to monitoring glucose and I open that up, and you'll see that here is an example of somebody who's on basal insulin only. They inject at night, so they give their insulin at night. They check in the morning before breakfast. And if their glucose is high, if the blood glucose is above target, then they're going to increase their basal insulin. And if their blood glucose is low, then they're going to decrease their basal insulin. So, that's a tool that you could use. So that's the one for recommending a monitoring schedule. Sharps disposal snacks, driving. So if I go back to the home page, where's the home page? I'm going to just open it up, grab my home page. So keeping people safe with diabetes, you go to the Drive Safe web guideline or PDF, and you can actually talk to them about Drive Safe. And this is a huge learning point or education thing. So as soon as you've actually also talked about the Drive Safe tool, sending a note back to the primary care provider or the whole diabetes education team and just letting them know that you discussed the Drive Safe guidelines with the patient is huge, because it's a big important learning point to keeping them safe. Instructions for oral medications. So I crossed off oral because we're really just talking about instructions for all the other medications. And that's a little bit about what I was saying about how you're going to decrease and you're going to increase. So you're going to already have maximized your GLP-1 and your SGLT2 as much as you can before you actually add your basal insulin. When it comes to adding, suppose I was to add, it's funny, if I was adding an SGLT2 to somebody who already is already on basal insulin, and we're at A1C target. So here's a question. I wonder if I could put it up in the chat. If they were already at target, and I'm jumping around a minute, but imagine if they were already at target, they have a basal insulin, they're already at target, and now I'm adding an SGLT2. I need to cut back the insulin because I'm adding an SGLT2. So what percentage do I cut back the basal insulin? Does anybody have any ideas? Do you want to put it up in the chat if you have any ideas? It's going to be a percentage. So, and you know what? To be honest with you, there's no right or wrong. Generally, we say 20%. Just cut it back by 20%, and then up titrate again. But that's an example of how you're going to need to be able to adjust medications. And then finally, dosing adjustments. And so for the dose adjustments, I was going to show you one of the websites that one of the tools that I also use. So going to the home page, going to the insulin prescription tool and opening that up. And if I go to the back page and I make that bigger, you can see when you add basal insulin, here it is. If you're starting you start at a low dose of 10 units, or you can start at an even lower dose for lean patients. If you're using Tresiba or if you're using other basal insulins, what's the up titration? And so you can see that's there. Increase if you're on Tresiba, which is the really long acting, right? Ultra long, whatever, long acting, you would increase by 2 to 4 units every week. That's an example. If you're using basal, any other basal insulin, you just increase by 1 dose every night until the fasting blood glucose is at target. So I know I've gone over that quickly, but I think from the poll, hopefully that also showed that we were quite comfortable with that. Key points are, just looking at the time, key points are that we talked about was the A1C, matching the glucose lowering agents by recognizing the priorities of care of the individual in front of you, adjusting any concurrent glucose lowering agents, talking if there's a risk of glycemia, talking about both hypoglycemia prevention and management, drive safe guidelines, and the sick day management, which we talked about for the SGLT2, but also important to make sure we've touched on here. And I just want to go over and take a look at some of the questions, and people can continue to ask questions as we go.
Okay, we still have time, so this is really good.
Excellent. So there's a question, I think, still about statins, and they have, so this person who was unable to tolerate a statin even at very low doses, and they have tried the slew of statins and there still are tolerance issues. Good question. So there are, quite honestly, there are even people who have genetic predispositions and they can't take it. So, you know, if you can't take it, let's not make them feel guilty about it or anything. But if, as long as I would have tried the pravastatin just to be sure if they could tolerate that one. The other thing we could also do is the CoQ10. You could also try seeing if, staying hydrated, things like that. But again, I think that it's, if they can't tolerate, then they can't tolerate it. Oh, here's another one. My patient could not tolerate even low doses of atorvastatin, rosuvastatin, pravastatin, and simvastatin. When referred to a lipid specialist, they were given prescriptions for benzofibrate and ezetimibe, which appears to be helping. So, so Colleen, thank you for sharing that. That is so lovely that we're all helping each other. So I think that the question is, do they still need it for a cholesterol lowering? Or because they're not necessarily going to get the cardiorenal protection of the statin, but if we need it to get to target of the cholesterol parameters, then definitely we need to look at the other agents. And so, ezetimibe, the PCSK9s, niacin, and things like that, definitely you'd want to look at those. And, I bet you if I didn't know the answer to that, could I use a website to find the answer? We probably could. If we go to I'm opening up lots of different windows, all Diabetes Canada at this point, but if I looked at the full guidelines and went down to where's lipids? Cardiovascular dyslipidemia, I bet you maybe the answer would be in there. So you could look at that. You could also look at videos and look at the video on dyslipidemia, which is probably the same number over wherever it is. But anyway, kind of in that where screening dyslipidemia. Okay, so those are just examples of how you might be able to find some resources on the website. Okay, let's look at a different one. Is it important to take into consideration the length of the time that the patient had diabetes when making these recommendations? So truthfully, no, because in so many times when you think about that whole continuum of diabetes, many times we have had diabetes growing in us or developing in us, sometimes even 10 to 15 years prior to actually seeing diabetes. So we actually don't look at the length of time, except for one exception, always exceptions. If I open up, and I'm going to open up another because I want to minute. So if I look at the quick reference guide, if you look at that same cardiovascular protection, we have to start saying at what, remember you were saying how many years since diagnosis? And so that one, it actually does have, if the person is over 30 and has had diabetes for more than 15 years. And so that's more people with type 1 diabetes, okay? But having said that, we would also consider if they are pregnant or trying to get pregnant, then we actually, depending if they have presence of kidney disease or not, we actually would stop the ASA or the statin, things like that, depending on the entire risk factor profile. Are we just using it for prevention, or do they actually have the presence of microvascular disease? Sometimes if they have the presence of microvascular disease, we continue it up right until pregnancy is determined. And other times during the planning stages of pregnancy, we would actually stop it. And the reason for that is that because sometimes when you're planning on getting pregnant, it can still take several years. Some other people, 1 month, but other people, it takes a lot longer. So we would also look at that and before we determine when we're going to stop it. But having said that, that's the only place that I can think of where we actually look at how long duration of diabetes. Other than that, duration of diabetes does have a role to play in our thought processes by way of the fact that we just know that the longer they've lived with diabetes, the longer they've had time to develop cardiovascular disease and microvascular disease, and things are actually worse. But having said that, because of the protective effect of it, it's more a matter of as soon as you know that they have type 2 diabetes, their risk has just naturally just increased. And so we would want to add those protective agents as soon as possible. Okay, so hopefully that answered that question. Oh, and Jeanette was answering 10%, perfect. That was the answer to whether at what dose do you cut back if you're at target and you're adding an SGLT2 or a GLP-1 to basal insulin, what do you cut back? So Jeanette was saying 10%. I believe the standard is actually 20%, but a lot of times it really depends. What's the A1C, right? If the A1C is way high, then I might just not even cut back, right? And a lot of that is I don't actually like A1C. We in Ontario are very blessed that we have access to flash glucose monitoring. Some of us have access to the push technology rather than the pull technology, and we have access to continuous glucose monitoring. So that would be like the Dexcom or, oh my gosh, I'm having a mind blank, but the other one. And I like using continuous glucose monitoring to really adjust my insulins if I can. Okay, Margaret has a good question. When would you recommend a DPP-4? And some people would actually say never. But let's look at it honestly. I think that maybe some people are being a little facetious, a little bit exaggerating, but certainly they are, for the bang for their buck, they're not as good as blood glucose lowering. They don't have the same CV protection. If I can't get them to target after really working on nutrition and healthy behavior interventions, I would consider it if they really couldn't tolerate a GLP-1. But like I said, I've actually had people do better on a lower dose GLP-1 and they were fine. I've actually had people, we've actually had to encourage them to listen to your body, only eat when you're hungry, stop when you're no longer hungry, don't eat past being full because you're just gonna, technically vomit or get really sick in the stomach because you've eaten beyond what you need to. So a lot of it is just listening to your body. I've recommended to people to reduce the amount of fatty foods that they're taking, the amount of spicy foods that they're taking. I've recommended staying hydrated when you're on the GLP-1. So there's so many things you can do to try to get them to tolerate these classes, to try to not need to use these classes. But I guess there is a need. And I guess maybe in the elderly, we might use it if they really can't tolerate, especially when you've got lowered kidney function. Having said that, many of these you can use right down to dialysis, or certainly an EGFR of 15. So there's often no need to actually stop these agents. So it's a good question. When would I use a DPP-4? I don't normally recommend a DPP-4. I would actually go with one of these if at all possible. What daily glucose monitoring, if any, should be done in my very frail elderly palliative patients? So that's an excellent question. I think a lot of it depends on what are their risks. And so I think, if we're looking at what are their risks, and what I'm actually talking about are they on insulin? Are they at risk of lows? I actually have absolutely recommended flash in a palliative patient because all we wanted to do, and they weren't eating much, so we didn't really need to, we only kept them on basal insulin the whole time, and I was okay as long as their sugar stayed between 8 and 15. Honestly, it was just like, let's just keep them there. And by watching what they ate, because they were on the flash, we were able to determine whether they were able to, eat certain foods. And quite honestly, at that point when they were palliative, I just said, let them eat as much as they want of whatever they want. And we'll just figure the rest out. And as long as we tried to keep the meals consistent, then as long as we were keeping them between 8 and 15, it was fine. I hope that helps answer that question. But I do like the interstitial glucose monitoring for a palliative patient, because then you're not pricking them so much and you're just seeing the data as much as you can. Okay, I have an obese elderly patient who started on basal insulin. She's using a 4mm pen insulin needle, and is experiencing lipohypertrophy with each injection site, even with site rotation. This is very troubling for her. Any recommendations? Good question. So I'm wondering if, so lipohypertrophy normally takes a while to develop, because it's often, it's an actual hardening of the skin underneath, right? So I'm wondering if she's actually experiencing more of a local reaction. And honestly, I've seen local reactions to either the steel or a different, or the silicone covering and things like that. So I think it might be an interesting idea to try a different kind of pen needle tip to see if it's more of a local reaction. Like, I'm wondering if you're saying if she injects it and she gets a hardening immediately, because that's what I think I'm reading, whereas normal lipohypertrophy takes maybe a week, maybe a month to kind of develop. So I think I would try a different pen. I wonder if it's more of a kind of reaction type.
I'm just going to put up my hand here and just make a pitch for a really good program that you could, that's free. It's on OPA's website. It's called Supporting Patients with Diabetes. And it's all about preventing lipohypertrophy and site rotation. And so perhaps if you took a look at that, it's a 4-webinar, it's about 2-hour program, but you can kind of zip through it. And it talks about more than just, site rotation. Maybe you can check the site rotation, about the size of the site rotation, and then how deep, how hard they push, because some people push too hard. And so there's lots of things in there. I had to, it's perfect.
Ruth, I'm so happy you did that. That's awesome.
And someone
that's awesome.
Put it in. I'm just going to be quiet now for a bit.
Yeah, no, that's awesome. Put it up in the chat. That would be good. Okay, I'm going to answer the next question. What non-pharmacologicals can we recommend for patients on an SGLT2 inhibitors with recurrent UTI or yeast infection? So excellent question. Sometimes what I'll recommend is I will ask them, we go over hygiene, making sure they're wiping from front to back. And, it's interesting, but when you have really obese people, they actually can't reach and they can't clean themselves well. So it is a matter of how are they cleaning themselves. And then I would also try to take a look at maybe what are they eating, because don't forget, it's a glucose dependent effect. So if they're eating a lot of fast acting sugars, for example, I'm going to give a bad example, but suppose they're having a lot of fruit drinks and soda pops and stuff like that, and their sugars are going up, so their postprandial just keeps going up, so they're going to be peeing out a lot of more sugar. So if we can just get them to avoid these more glucosuria, then we'll have less issues there to a certain extent. But I get it that sometimes you can't do that. And sometimes it's a matter of they're always leaking. So it's a matter of seeing do they have urinary incontinence, and can we do anything for that? So non-pharmacologicals, you can actually encourage Kegels. I've actually had somebody who did Kegel exercises, and it was very effective at just retraining the bowels or retraining their ureter muscles, and then they were actually able to not leak as much. So that's another idea. And then of course we could also just go with preventative pharmacologicals that I have had people take just for treatment, just like the diflucan and things like that. For the yeast infection. I'm trying to think if I can think of anything else. No, but I think that's what I would do. I know that you could do cranberry juice or not the cranberry capsules, sorry, would never go juice. The capsules, if you wanted to try to support it, but essentially I think it really comes down to proper cleaning and possibly trying to watch what you're eating and staying hydrated. Even though staying hydrated, of course, why are you staying hydrated? They're going to pee it out more, but essentially you're going to be peeing less of a concentrated glucose stream. Okay, if a patient won't take a statin but does not have CVD, could you use an SGLT2 instead for cardioprotection? So they work differently. Certainly they would add to each other. I think that our questions would be, what are they willing to take and what can they take? But if they don't have CVD, then the question is, what are we using to benefit the SGLT2? So I'm going to switch over to the website, over to here. And if they did not have CVD, so I think it's your question that they have CKD or heart failure. And if they have that, they would benefit grade A evidence from an SGLT2 for the lowering the risk of hospitalization for heart failure, lowering the risk for progression of nephropathy. Okay, so they would benefit from the SGLT2 in that case, if we're looking at these populations. But if we're looking at the statin, what would they be missing? So in that case, remember we were saying that the person had CKD, right? They had kidney disease. So they're not going to benefit, they would still be missing something, so you still try, but if they won't take it, then they won't take it. So at least they're getting something else. I hope that answers that. You're still gonna, I don't think it replaces it, but it certainly because in your question, it says the person does not have CVD. So in my answer, I'm saying, well, what are they benefiting from it? What are they using it for? And if it's either for glucose lowering or for prevention of hospitalization for heart failure or progression of nephropathy in the population of person with CKD or person with heart failure. So hopefully that answers that question. There's another question. What comment do you have for a female patient that is in her mid-50s with type 2 diabetes and rheumatoid arthritis? I noticed that this patient was not on a statin. I provided the Diabetes Canada information on reducing cardiovascular disease risk. The doctor said that the patient did not need a statin as her LDL was at target and her HDL was at target. Should the patient be on a statin? So she's mid-50s. So yeah, as soon as she's mid-50s, so she's over 40. So she would benefit. So this is an interesting question. It's almost very similar to the other question, is how do you handle it? And I love these questions because it's so true. Many times we are more educated or aware of clinical practice guidelines. And so in this case, the doctor actually said that the patient does not need a statin. So I'm wondering if we would then be able to either show them this tool. You can either get this printed off and just highlight that the person has type 2 diabetes and is over the age of 40, and therefore, based on the Diabetes Canada clinical practice guidelines, would benefit from a statin, even if the person is at A1C target. You could even, there's an app that you could show them, but again, it's also in the quick reference guide, but it was under reducing vascular risk. So the same thing. So as soon as you put in the person's, the person is 55, right? So as soon as you say no, but as soon as they're 55 and you submit, I don't know how long the person, but let's say they're newly diagnosed. Even if they're newly diagnosed, even if they don't have any of those things, it would say a statin. So I don't know, it's hard to, except for the fact that you absolutely know that they would benefit from it. So it's just a matter of telling the physician that actually, independent of A1C, they would benefit from it. The studies have shown. Okay, suggest a great handout. John Hopkins bladder irritants list is useful. Thank you, Colleen. So that was the question about what to do when you have, or non-pharmacologicals that you can recommend to a patient on SGLT2 inhibitors with recurrent UTI. And that's the handout from the John Hopkins bladder irritants list. Colleen says, I see more people with UTIs at Christmas due to chocolate and alcohol use. Interesting. I also find more UTIs in strawberry and tomato season because it's acidic and it's on the John Hopkins bladder irritants list. Thank you, Colleen. Thank you for sharing that. That's awesome. Oh, and then she's actually also posted it. So I'm actually going to also download that and grab that for myself. All righty. I think, let me just double check the chat.
I think we've run out of questions.
Wonderful. I hope that it was helpful for everybody then.
I want to thank you, Susie. This was fantastic. It's almost, can you put this in your phone or something so you can, what a really helpful to show people where to go. It's I love using the PO so we can link back and forth, and all these resources will be available. This recording will also be available on the website. Yeah, this was really, really interesting and so practical. Thank you. You always do well, but it was just,
True.
you know, it's helpful to see exactly where to go, because the guidelines are so huge, right?
It's true. And it's so nice that hopefully that you can navigate through them and understand how to use them in your practice. So these are literally how I've actually helped people in my practice. So hopefully that's
fantastic. So again, thank you very much. And I want to wish everybody a great evening, what's left of it. And we hope to see you soon. Lots of right doses coming up. So
awesome.
Take care.
Thank you.
Bye,
And thank
everybody.
you, OPA. Thank you, Ruth.
Bye.